All right, we'll get back started after our little break. So I know that Dr. Mogdateri posted his link in the chat and then also during his talk. But if you enjoyed his presentation today, you can check out his comprehensive guide on orthopedic x-rays and how to read them most efficiently and effectively at this QR code or at the link that he posted in the chat. This link takes you to the guide embedded within the MSOS website, but now it looks like it has its own home. So check out the link that he posted in the chat. And then if you want to hear more from Thomas and Ellen, check out the Cooper 101 sub-internship course led by the residents at the University at Buffalo. This 5-week virtual course will take you through the basics of X-ray reading, consults, principles of bone healing, more on plates and screws, case preparation, and more. I took this course actually last year when I was preparing for my sub-Is, and it was super helpful for me. So this is an awesome thing for you guys to check out. And then as far as MSOS resources, we've worked really hard to create the Ortho Navigator, a one-stop resource designed to support medical students pursuing orthopedics. This is now live on the MSOS website, and it's a comprehensive tool that offers guidance on building your orthopedic network, strengthening research skills, expanding your orthopedic knowledge base, and preparing your ERAS application. So we want to show you some of the things that this offers. We have this resource center, which shows comprehensive resources amongst all disciplines. So be sure to check that out. And then also be sure to check out our resources and research section for a wealth of information. And then check out the 4th year section for key timelines and tools to help you navigate everything from sub-I applications to match. And then I'll pass it to Precious for our last panel of the day.
Thank you, Hayden. And now on to our final event of the Sub-I Summit, a panel on maximizing your time in the OR while on rotation. My name is Precious Annie, and alongside me is my co-moderator, Patrick Lawler, and we are privileged to have 6 esteemed panelists consisting of 3 attendings and 3 residents who will share their perspectives on how rotators can stand out in the operative setting. These questions are centered on the soft skills, preparation, common mistakes, and general recommendations for rotators looking to excel while scrubbed in. So with that, we'll start with brief introductions of our panelists. First and foremost, we have Dr. Dawn Laporte, an orthopedic hand surgeon and residency program director at Johns Hopkins. Dr. Laporte completed her residency training at Hopkins and fellowship at the Curtis National Hand Center. She was the Ruth Jackson Orthopedic Society president in 2020 and is now the chair of the DEI force. Next, we have Dr. Jesse Hand, an orthopedic trauma surgeon at the University of Vermont. He completed his residency training at the UVM and fellowship training in the orthopedic traumatology at UCSF. Additionally, he has a master's of public health from UC Berkeley. We are also joined by Dr. Lisa Canada, an orthopedic trauma surgeon and adjunct professor at the University of North Carolina Department of Orthopedics, where she also serves as Director of Faculty Integrations at UNC Charlotte. She completed her residency training at Case Western Reserve University and fellowship in orthopedic trauma at the University of Maryland. She serves as the Ruth Jackson Orthopedic Society president in 2011 and is now the chair of the Development Committee.
And moving on to our residents, we have David Kantrowitz. He's a 5th year at Mount Sinai. David completed his medical school at Columbia University and attended Duke for undergrad. He will complete his fellowship training in orthopedic sports medicine at the American Sports Medicine Institute. Next up, Ian Penvos is a 3rd year at Brown University. He completed medical school at Oakland University's School of Medicine and completed his undergraduate education at Northeastern. And finally, Evan Bailey is a PGY2 at Emory University. He completed his medical school at Medical University of South Carolina and attended undergrad at the College of Charleston, where he played on the basketball team there. I want to thank all of our panelists and everyone here for joining us. We'll direct our questions to 2 panelists at a time, but of course, all panelists, please feel open to hopping in on any question if you feel like you'd like to. And to all of our attendees, please feel free to drop questions in the chat. So moving on to our first question, I'll direct it to Dr. Laporta first, and then Dr. Hahn. At the beginning of a sub-I, and as a sub-I starts working with you, how can these medical students make a strong first impression with you in the OR? Dr. Laporta?
Thanks. And thank you for having me here. It's good to see so many people. So how to make a great first impression, because you only have one opportunity to make a great first impression. I think it's really important and maybe undervalued to know about the patient and know what the diagnosis is and why that patient's having surgery. So, before you even look at what the procedure is and what to do, know the patient, know why they're there and why you're treating them this way. I also think it's really important to know the anatomy. And we don't expect students necessarily to know the nuances of what screw or implant we're going to be using, but you should be able to look up the anatomy, know what structures are there, what you're looking out for. Um, and so I think that's really helpful. Other sort of soft skills things when you walk into the OR, introduce yourself not just to your attending and the residents, but introduce yourself to the scrub tech and to the nurses and to the anesthesia team, and look for ways that you can be helpful. I think those are different things that stand out. And remember that the residents are probably your best allies. So take prompts from the residents. And some teams have advanced practice providers that work with a surgeon all the time, and they can give you great tips, and listen to the scrub tech too. They often have great insight.
Thank you for that. Dr. Hahn?
Yeah, I would agree with everything that Dr. Laporte just said. In addition, I work in trauma, so knowing the patient includes knowing not just their orthopedic injury list, but their whole injury list. So make sure you have a full understanding of what brought them to the operating room and also other comorbidities that they might have and other injuries, C-spine, head, everything. So it's, the bone is often the minimal part of their whole package. So understanding all that. And also, the resident is the conduit to the attending. So if you're helpful to the resident, that shows, and we know about it. So the more helpful you are to the resident indirectly, the more helpful you are to us. And I think also just being kind, just being a kind person to the patients, meeting the patient beforehand and being kind to them and treating them just like you would want to be treated and you'd want your loved one to be treated. That goes a long way. And being kind to everybody in the operating room. For the patient, this is probably one of the worst days of their life. Being in the operating room and going under anesthesia is pretty scary and terrifying. So respecting that and being kind to them really goes a long way.
Thank you for that commentary, both of you. Our next question will go to Dr. Canada and then followed by David. What are the most important ways a sub-I can prepare for an OR day, both in terms of knowledge and logistics? In other words, what do you personally expect from your sub-Is to know before each case?
Well, first, thank you for having me on this panel. This is so important. And I kind of think about when you talk about how to prepare, I'm just going to talk about this is takes TNT. My principle is it takes no talent principle to make a good first impression and be prepared for your first day. TNT, that means show up early. Doesn't take anything to show up early. Doesn't take any talent, just setting your alarm, showing up early, and bring the necessary items. You never know, especially when you're first starting. You might be hungry, bring bars, bring a notebook, and always have, me, I'm a trauma surgeon. One of the things that's most important is always have scissors because we always got to cut off splints. Always have that. That's in have some bandages ready for when you're making your rounds. So those are things that don't take any talent. And I tell that you when you go in the OR, I always train everybody to introduce yourself, especially pay attention to the blue sterile area. Put your name on the board right away so that they know who you are and what your gear is. So those are some good, easy things to prepare for the OR. And other things, once you have your access to Epic or whatever electronic medical record, read about the patient, read about them in advance, and pay attention to the red flags. You don't know what's important, right? You don't know. Pay attention to anything that has a little red flag value to it, because that will help you in crucial areas. So I'll let someone else provide more answers, but those are some tips to make your good first impression for your first day in the OR.
David?
I agree with all that stuff. That's a little bit more on the logistics side. I guess on the knowledge side, I would say you need to get as much information about the patient as you can, which can be difficult as a rotator. Epic was just mentioned. At our institution, our away rotators don't have Epic access sometimes, which can be really challenging. So you need to ask the resident that you're with, communicate with them the night before say, hey, what are the cases we're doing tomorrow? And if they just respond and say, it's an ACL. That's not enough information, and you can probe them for more, and they'll give you more, but they're just kind of waiting for you to ask because students come at all different kind of levels of inquisitiveness, and so say, can I talk with you more about that case? Find out what graft you're using, find out all the questions that you want to get answered, and then go read about that stuff. I think Netters is a great resource for local anatomy. Case Files is pretty good for kind of understanding the frame of reference for the patient's pathology. Pocket Pimped is a really good book for questions you might get asked in the operating room. ViewMedi is a great account. If you guys don't have ViewMedi accounts made, I would really encourage you to make one. And then you can look up the surgery that you're going to be doing and you can watch it, which helps you just immensely the next day, kind of recognize the things that you already have seen once. So those are the kind of things that I would recommend doing to prepare knowledge-wise.
Those were both really great answers. It sounds like there's very simple things we can do, as well as just being present, as well as the knowledge about the patient and the case and the technique. So thank you both for those answers. Our next question, I'll direct it to Ian first and then to Evan. So from your experience working with sub-Is in the OR and then evaluating them, what are some of the attributes that really stand out to you from a resident perspective when you all are meeting together and discussing the sub-Is? What are the attributes that stand out?
Yeah, absolutely. And again, really appreciate you guys having me here. I think some of the attributes which have been touched upon a little bit previously is the first one is kind of punctuality, making sure that you're there with well enough time in advance to prepare. And also, a lot of time, rotators, especially at different institutions, this is a new place that you haven't been before. So, really getting yourself acclimated will benefit you. And I think kind of the next step after punctuality is also a respect thing. When you kind of enter the operating room, my biggest piece of advice is to introduce yourself to everybody. The circulator, as well as the scrub tech, the x-ray tech, they can be tremendously helpful during your rotation. When you're scrubbed in, helping cases, the scrub tech may knows the case very well. They may be able to hand you the instrument that's coming next. So really setting a good kind of foundation for respect and getting to know individuals, I think will definitely help. On the first day, we don't really expect a whole lot because we know that you're new to our institution and you're trying to get kind of the groundwork as best as anybody. So really just being present and being very observant, I think can bode well. If you are, regardless of which service you're on, kind of seeing the workflow between when the patient comes into the operating room, kind of the steps that the resident takes to help the team and the circulator nurse or the scrub tech prepare for the case, as well as then what happens afterwards in terms of walking the patient to the PACU. And if you're very detailed and observant, then you can start to pick up on the little things that can then be extremely helpful. You see that the patient is rolled in, you can start grabbing supplies. If a tourniquet needs to be applied, whatever it may be, you'll have the supplies ready for the tourniquet. You'll have the prep solutions ready to go. And I think that shows us as residents that you're observant, you want to help, and you take that initiative to really be involved. And so those are some of the initial things that I think we really appreciate and notice, and can bode really well for our rotators.
Yeah, I definitely agree with a lot of what Ian had to say. I think being present and just thinking about the next step is super important. Even in the ORs, a lot of the stuff we do is patterns. So if you've already prepped a leg before, even if it's a femur versus a tibia, you kind of know what supplies you need to use and have ready for the next patient, which, like Ian said, we don't expect you to know on the first case, but the next day, try to write things down and pick stuff up. And that'll really show because once we know that you can prep something the right way, then we can let you do other things like start to suture and then maybe ream for a nail and those kind of things. So if you keep showing that you're following and seeing those patterns, I think that really helps you to show the attending and resident that you're there. And then one thing that I think it's what was told to me, and I think it's been being told to a lot of med students now is be seen but not heard. I don't really know if I agree as much with that statement. I think it's really important to figure out good times in the case to ask really inquisitive questions, whether that's like when the bone cement's drying during a total knee. That's a good time to ask like a not a question like, hey, what's that anatomy, but like something that maybe is controversial that you've read about in the night before, so it can kind of show that you're being prepared for the case, but not asking it at like the worst time, maybe when the bone cut didn't go well on the femur. You don't want to ask a question there, but when the bone cement's drying is a good time to ask questions. So continue to be inquisitive and then follow those patterns to see where you can be helpful.
Thank you both, Ian and Evan, for that. You guys kind of laid the groundwork on our next question about initiative. So I'll direct this question to Dr. Laporte and Dr. Hahn. How can a sub-I actively participate in a case while staying active within their role? Or in other words, what are some subtle but effective ways to show initiative in the OR without overstepping boundaries?
Okay, I guess I can start and agree. Both laid some great groundwork for that. So taking initiative can start before the case. As you both noted, if there's a tourniquet to be put on, you can put on the tourniquet. You can open gloves, not only for yourself, but for the team. Check with the scrub tech first to make sure they're okay with that. But that can be helpful and show that you're taking initiative, help setting up the patient. And then during the case, if you've read about it and you know what the steps are, try to be thinking about what the next step is and follow the surgeon and anticipate where they're going. So if you're holding the suction, you're following along with them. And, if they're giving you feedback, you're responding to that. So, you're typically the second or sometimes even third assist in the OR. So it's really kind of following cues once you're in the case, but paying attention, staying alert. And I like, the comment about asking questions or speaking at appropriate times. And some of that takes a little bit of, getting to know your team and reading the room. But that's a good way to show that you've read about, the patient, you've read about the case, and you also have a good feel for, when it's okay to be speaking up and sharing that knowledge.
Dr. Hunt, anything to add?
Sure. Yeah, I think those are great thoughts. I like to tell the residents and everybody in the OR that everybody's an ORA. I mean, there may be different names at your different institutions, OR Tech, et cetera, but everybody's an ORA, just like the Marines. Everybody's a rifleman. That's your basic skill. So in the operating room, everybody can help with moving the patient over safely, and it's everybody's responsibility in the OR to make sure the patient's safe at all times. So that's something that you can do. And just like Dr. Canada said, that takes zero talent to do. Nothing against ORAs, but that takes zero, advanced experience or training to do it to make sure that the patient's safe. So you can watch what the ORAs are doing and their hustle and help with that. It can help with turnovers of the room. Nobody's expecting you to mop the floors, but helping the ORAs, turn over the beds, switch beds, move and be helpful. That's very simple stuff with prepping the room and getting that open. And then in the operating room, yeah, follow along with what's going along and know when it's a good time to ask questions. If you don't know, if it's just like tense all the time, which I certainly remember those days, it's okay to say, "Hey, is this a good time to ask a question?" The worst your answer you're gonna get is no. Nobody's going to kill you for that. So if you don't know, you can always just ask if it's a good time to ask a question. And then, in tense cases, for me, like an acetabular or something, you do what hopefully your attending or your chief resident is going to tell you what to do, and do that. Don't do anything other than that, but do that. So don't try to overreach what you may think you can do and think to be helpful. Just be helpful as you're told to be helpful, because sometimes putting a retractor or a Holman in an errant place can be not a great thing. So when you're told what to do, do that, and don't try to overreach. And don't ask the scrub tech for things unless you know that's exactly what is needed, because that may distract them from what the attending is asking for.
Yeah, those are both really good perspectives on just being proactive, reading the room, and building that trust with your team through communication and kind of anticipation. We're kind of touching on some of the technical skills, and I know that's not an imperative part to an application. It may not be make or break as in related to some of the other soft skills. But I just wanted to ask a couple of our residents, Ian first and then David, what are some basic technical skills that a sub-I should be expected to be able to perform? And then what are some more advanced technical skills within the OR, whether during the operation or before or after, that would be really considered great for a sub-I to have a working knowledge of?
Yeah, sure. I can start. I think, basic technical skills is, I think it comes up in every single case is suturing. Oftentimes at the end of the case, the attending may scrub out and it's just left with you and the resident. And I think those are really valuable times to spend one-on-one time for the resident. I think sometimes that can be an opportunity to potentially ask a little bit more questions. I think sometimes the relationship between residents and sub-Is can feel a little bit more relaxed than they are with attending. So being able to kind of develop rapport during that time and as a resident, I really do enjoy teaching as well. So, being able to see your suturing skills and kind of show you different techniques to improve upon those skills, I think can be really beneficial. And typically, we do have a little bit of time, so we can kind of have you work through some of the suturing and really allow you to focus and kind of improve upon your skills. In terms of maybe a little bit more advanced. And it really is kind of a case by case situation. But really, if you kind of develop that rapport and you show that you can be trusted and you've done a really good job, then we may allow you to participate a little bit more in the case. So if it's a case, maybe the residents are kind of walking through the case, then we can have you actively participate, whether or not that's putting in screws or reaming or something along those lines. It really is a trusting relationship. And I think if you can show everyone in the room that you're taking initiative, you're respectful, and we can trust you, will allow you and get you more involved in the appropriate setting. So I think those are some of the technical aspects that we can really work on you one-on-one when you're a rotator.
Yeah, I agree with all of that. I think the concept of someone having good hands or good technical skills, that assessment starts the minute you walk in the room and people make a quick impression of you. So looking comfortable and knowing what to do, getting gowned and gloved fluidly, already knowing the scrub tech's name, saying hello to them. They have their gloves for you. Starting off with, oh, you didn't open your gloves is a terrible way to unfortunately start that case. Not knowing how to, spin around properly, coming over with your hands like way up in the air. It makes people a little on edge because you look very new. So just looking relaxed, talking to other rotators, people a year ahead of you, some of the residents about where do I, if you don't know, where do I put my hands? Which side of the table should I stand on? Asking that stuff in advance, knowing how to spin back to back with an attending or resident when you move around because your back's not sterile. All that stuff contributes, I think, to like gross technical skills. Retractor holding, which Dr. Hahn mentioned, if someone gives you a retractor, hold it with kind of the amount of pressure or tension that they kind of showed you to hold it. Don't pull so hard when we're not working in that area and, we're off to the side getting a different instrument. You can relax on the retractor, don't, but at the same time, toe in if you need to toe in and don't move until they move it for you. And if someone does grab your retractor, loosen your grip a little so we can replace it. Those are just like, it gives a feel of someone in the OR having good technical abilities versus everything feels kind of rigid with that student. More granularly, I think a lot of it is suturing, how to cut, how to use scissors properly and how to cut our knots, not cutting knots out if they're nylons, leaving the tails long. If it's a, deep dermal buried layer, cutting the tails very short. Ask if you're not sure. How do you want this tail short, long? That kind of stuff. Following, if a resident is running a monocryl, knowing what it is to like follow them and help hold the tail, blot with the lap, cut if they need you to cut. And then obviously suturing, those opportunities will come, like Ian said, where it's just you and a resident, you have a big wound, and it's great. I love it when a sub-I is pretty good at suturing, and I can give them an area of the incision to suture, and they actually help me get out of there faster. Everyone has different amounts of practice, but I would recommend buying like a surgical suturing board or a kit and definitely practice. And then, yeah, the more like high level stuff will sometimes come, sometimes not come. Some tools you've never used before. And the first time that you use it, you're in a joints case and someone says, all right, put these pins in to this jig and you don't know how to use the drill, like which trigger is which, and you have to hold, to hold the pin down. So if you see those tools and you see them being used a lot, you can chat with the resident about how to use it. If you'll ever have a chance to use it, what should you do? But that stuff doesn't always come up that often.
Thank you both for that insight. It sounds like we need to do a lot of practice on sutures, but even in the OR, we have opportunities to ask questions if we don't know. So our next question, we'll start with Dr. Canada and then we'll transition to Evan, is what are some common mistakes sub-Is make in the OR and how can we effectively avoid them?
Well, first, for everyone that's going to be a sub-I, you will make a mistake, so don't let that define or ruin your day. So how you bounce back from it will be noted. A couple things that can happen is you contaminate the sterile field, and that's a big one. So it becomes important that you or know about your movements, keep your hands above your waist at all times, ask before you touch anything. That's a mistake. And if you contaminate it, you step away and you let them take care of it. We know you're going to apologize, and you can do it in public. You can also do it in private later. That's a given. I want to talk about, I have medical students that are so excited, but it's their first time they're in the OR, and this isn't a mistake, but it's something that happens that they pass out. They feel like they're going to pass out. So I always try and tell people in advance, I tell them if for everyone, their first day, I address it to everybody in the room. This is their first day with us. And I tell them if you're going to get sick or feel like you need a break, just let anyone know. So the best thing, if that's going to happen, if you feel like you're getting lightheaded, back away into a wall and you can contaminate yourself. It happens. It happens to the best of us. I know, I knew I wanted to do orthopedics from the beginning, but I was so excited and couldn't breathe because it was so hot. The first time I went in the operating room, I hit the deck. So it's really important to, make up for that. And the biggest thing for me is never look at that phone. That phone does not belong in the operating room. That phone, it needs to be on silent and the other thing I'm just going to give you, if you have, emergency breakthrough for families and all that, if they call you in the middle of the hour and it starts this weird song or something, they're going to remember that and it could be at the worst time. So not only put your phone on do not disturb, but make sure your volume's down for those people that are emergency contacts. And I think the other thing is the way you look. Again, the way you look. You keep your shirt tucked in. You don't keep your shirt untucked in the operating room. That can hit something. So avoid looking sloppy because then we are going to think that you will do other things sloppy. So always make sure your scrubs, your shoes are cleaned. You don't want to have that blood from the last case when you go and talk to people and round on the floor. So, little things. Don't get sloppy, don't look sloppy. If you make a mistake, everyone's going to make a mistake. It's how you react to it that's going to define you.
Yeah, I think the biggest mistake I've seen students make recently, and it's not anything that's hard not to do, but just being engaged in the case. You can be in those long tab cases or pelvis cases on trauma rotations, and I just look over and I'm like intently trying to follow the attending, and the med student's just like looking at the ceiling, not even though they're retracting on the other side and they don't see much, like you still need to stay engaged and make sure your hands are in the right position. And I know it's hard to focus for a long time, but that's what you're going to be doing as a resident. So it's just important to stay engaged in the case, no matter how hard that is. Um, and then the other thing is kind of the OR, first of all, is to make sure the patient has a good surgery. Second is to educate the resident because the resident is the one that's going to become the surgeon before the med student. And then third is kind of educating the med student, showing them the proper anatomy. So just keep that in mind that it's not that you're like the last option or you're any less of than the resident or the attending, but the attending is trying to teach the residents. So if you got to make sure the resident can see. So I've had med students like they obviously want to see and they're like stepping on my toes and trying to get in front of me. And we will show you the anatomy when it's ready. But a lot of the times, just kind of sit back. If you need a step stool because you're a little bit shorter, That's okay. Ask for one. Um, and then I guess I'll just end with my mistakes that I made in the OR when I was a med student. I'm very tall, and I always hit my head on the light handles and contaminate them. And I did that like 5 or 6 times in one case with the chair at my medical school. And he just told me to go sit down. And I think he obviously wasn't mad or anything about it, but I apologized afterwards. And then that's kind of something that I joke about before cases with residents and stuff, and I try to keep that in mind. So if you've made a mistake before, just learn from it, and it's okay. You can still somehow become a resident like I did. But just continue to learn from your mistakes and get better from them.
Yeah, those are both really, really good points, Dr. Canada. That point about mistakes are inevitable, especially as a sub-I, but it's your response to it is such a good perspective that I hope our attendees can take forward. And then I don't have to worry about the height piece hitting the light, but because I'm a little shorter. But I think learning from your mistakes, knowing your role within the OR, those are great points, Evan. We're touching on questions a little bit, questions within the OR from the student to the team and kind of when to ask and how. But I just wanted to ask again and hear from both Dr. Hahn and then Ian after him. Can you talk a little bit about students asking questions? When should they do it? How should they do it? What kind of questions foster learning, as well as demonstrating a baseline understanding of the case and the patient and the technique? Can you talk a little, can you just demystify a little bit asking questions in the OR?
Sure. They're like I said before, if you don't know when to ask a question, it's okay to ask. I think in just read the room in terms of the tenor and the temperature. If the attending is cursing underneath his or her breath or above their breath, then it's probably not a good time to ask a question. And I think the things that we recommended that we talked about are helpful to make a good first impression in terms of knowing the patient, knowing their comorbidities, knowing what got them there. Those aren't the questions to ask because then that will reveal that you're not prepared. So anything that's going to reveal that you're not prepared about the basics of the patient, probably don't want to ask those questions. You know, and we all know, I mean, we've all been there. We all have been in your shoes, and we know that this is kind of an audition. So it's okay, and we kind of understand, like if you've read about the anatomy, it's okay to ask some leading questions that help you demonstrate that you've read. Like, say for a tibial plateau, if we're doing a lateral approach and you see the iliotibial band in there, you can ask, is that Gertie's tubercle, or, if you've done your submeniscal anatomy, is this, so are you putting those stitches into the, tibial meniscal ligaments? Are you retracting? Are we trying to get a look? Are we going to do our submeniscal arthrotomy now? It's okay to ask those questions, at least in my opinion. That shows, that demonstrates, you're kind of showing off a little bit that you read, and it also demonstrates the attending, yes, they have read. So, those are kind of my thoughts. I don't know if anybody has any other input.
Yeah, I think it can be one of the most challenging things as a rotator. I think I remember my kind of experience. You want to show that you're engaged in the case, but you're trying to find that right time. And I really do think that just comes with more comfortability in understanding the situation and reading the room. And I think, talking with the resident beforehand and trying to understand kind of, what the case is and, um, you know, that may allow you to get a better gauge on when is the appropriate time to ask questions, and you may even be able to get a little bit of information about the attending too. Are they someone who is going to be more vocal in the operating room, and is the attending going to be asking you a lot of questions, and you can kind of prepare them, and then you can kind of work off of that and maybe ask some follow-up questions. I think Evan had mentioned earlier, one way that you can show that you've kind of read about the case the night before is maybe looking up some interesting articles or new literature that has just come out. And we definitely don't expect that, but maybe there's been a discussion or a journal club at your home institution, and now you're going into a case And at the right time, you may be able to ask one of those questions to get a new perspective from a new institution about maybe their protocols or why they do it a certain way. So, from a resident perspective, I don't think that we ever evaluate necessarily a rotating student based on the questions that they ask in the operating room. But I think that it shows a lot by asking appropriate questions at the right time. And I think more so, doing the right things behind the scenes, being respectful, kind of helping get set up, kind of understanding your role in the operating room is going to go a lot further. And then being able to find those right times to interject those questions, I think can just aid in your experience and aid in showing us that you understand kind of what's going on in the situation at hand.
Thank you both. I believe asking questions is a perfect way to show that you're engaged in the case, but also knowing how to ask the question at the perfect time. Before we move forward, I did want to circle back. Dr. Laporte, did you want to chime in on the previous question about mistakes in the OR? I saw you were muted.
Oh, yeah. I was just going to add a couple of things, and I like Dr. Moghadari's story. So it definitely happens to everyone. Everyone makes mistakes, but other things to think of: don't take instruments off the scrub tech's table. They definitely don't like you grubbing at stuff on their table. And then there's been a lot of just comments about reading the room. Um, you know, we've had visiting students ask, does it always bleed this much? Think before you ask a question, because that may not be a good question to ask in the room. You can ask a resident that after the case is done.
Thank you so much for that additional insight. And then for our next question, this will go to Dr. Canada and then Dr. Laporte again. What's the best way for a sub-I to handle being asked a question they don't know the answer to?
The first thing is admit what you don't know. Don't try and cover it up. Use it as a growth mindset, an example of a growth mindset. And you can answer depending on, I don't know, but I'd like to learn. If it's about anatomy, can you show, if it's something you don't understand that they were asking for, I'd like to learn. I'm not certain, but this is what I think the answer would be if it's, about a procedure. And promise to do your research and follow up on it, actually follow up on it. That's the biggest thing. And I want to say, after every day, this is the beginning of a journey that lasts a lifetime where you want to have continuous growth. At the end of every day, take some notes, whether, it's on your phone or whether you keep a journal, for a tibia case, because that will help you at your next acting internship. It will help you when you are a resident. So, handling, when you get a question you don't know, it's an opportunity to grow and you will never get it wrong again.
Yeah, I completely agree with all of that. Definitely, if you don't know, admit that you don't know. If you read something that was, related or similar, you could say, "I don't know that, but when I was reading, I saw X, Y, or Z." If it's whatever it is, it's definitely good to go back and read about it. And whether you come back to whoever asked you the question in the next case or the next day, I think that's really important. Like, thank you for that question. I read about it, and just briefly. But I would tell our junior residents the same thing. And then same comment about taking notes and having ideally an organized way to do that. We tell our interns and junior residents the same thing, and you'll find what works for you. And you can ask. Actually, it'd be interesting to know what the residents who are on use, but some of them use Evernote, and you can put in, ultimately you can feed in X-rays and images, and it's a great repository that will help you on your other ways, and ultimately when you're a resident.
Yeah, that's really good perspective. Thank you for that on being honest, establishing that trust through integrity in your communication, as well as following up so you don't get the same question wrong twice. Moving on to our next question. I'll direct it to David first and then Evan. How can a sub-I contribute to post-op care and follow-up after the case? I understand expectations post-operatively may be institution-specific for sub-Is, but from your perspective, what are the most helpful ways a sub-I can contribute to the post-op care?
It's probably one of the more difficult ways for you guys to actually be helpful. If you have Epic Access and you can help with some of the, like typical things that we'll do is, a brief op note. Sometimes the op note is written by the resident, often dictated by the surgeon. Meds are sent, discharge instructions are put in. I don't think I've ever had a student do that stuff. It's pretty rare and would require a lot of trust and also just knowledge. And, you guys can't prescribe narcotics, stuff like that. So that's you're limited there. I think discussing the post-op care with the resident is a big part of that, just to show that you're interested in it and to gain the knowledge. And you do a rotator cuff and you say, what does the post-op care look like for this patient? How long do they wear their sling? How long are they non-weight bearing? When do they start PT? And then asking, the immediate post-op moment of helping wheel them to the PACU is helpful. And then asking the residents, is there anything else that I can do? Sometimes we'll get an X-ray in the PACU before we put on a knee immobilizer. Sometimes there's little things that you can be helpful with, and the resident might say, actually, yeah, you can go grab a knee immobilizer for this patient. They'll need one, or crutches, or there's some things. So I guess asking how you can be helpful, discussing the post-op care, and then if there's ever an opportunity to see a patient in the clinic afterwards, the continuity of care is always great. Even as residents, sometimes it's hard to get that. So being on the lookout for that and remembering the patients that you've treated, if you see them on rounds or if you see them in the clinic, they always like, re-engaging with the people, the providers that help them. So
Yeah, I definitely agree with David. It's hard as a med student to kind of participate in that, especially because, I mean, we all trust the med students, but to a point, just because if something goes wrong, it's the resident's fault. So I'm not going to have a med student do a post-op check for me. And even though I believe that you guys can do it, I need to see it for myself that the patient's wiggling their toes or if it's a spine doing a strength exam. So I think reminding the resident to do certain things. So if the resident's like, oh, I got to remember to go see this patient, or I got to remember to get this person this thing, like David was saying, a knee immobilizer or crutches, reminding the resident in a subtle, tasteful way, like, hey, we haven't done that yet. Can I help you do that? Or do you want to go see Mr. So and so? I think those kind of things go a long way because it shows like I feel like I keep coming back to it, just like staying engaged and following along because then you know that when you're a resident, you're going to keep doing those things. All these things we're talking about now, it's good for med students to do, but you got to take this into residency because introducing yourself to the scrub tech is going to keep happening. Like even I see attendings when it's a new scrub tech, they're always introducing themselves. So this isn't something that stops now during your fourth year sub-Is. This is something that like you got to take and build upon and keep doing for the rest of your career.
add one more thing, which is I've had a lot of sub-Is on joint services, and if you're doing the same cases over and over, particularly with the same few attendings, you can learn how each attending maybe does like dressings, for example. People are using, no one's really using drains anymore and things like that. But I know we have a couple attendings that will do a compressive ACE on the first post-op day, and then we take it down on post-op day one on rounds. We'll take it down. Sometimes certain people want a dressing change on the third post-op day. So knowing, getting that information from the resident, writing it down, and remembering it, kind of like Dr. Laporte said, taking notes so you know what this stuff is and you're not asking them again. And then you can impress your resident when, on post-op day 3 for that patient, you can say, hey, I just want to double check, but we're taking down that dressing, right? I have one ready to change it. So that's a way to be helpful.
Thank you both. I think a common theme that I've seen is just pattern recognition, and being observant of your surroundings. So our next question will go to Dr. Hahn first and then Ian. What are some strategies for managing long OR days and staying engaged?
So I got to admit, when I first read this question, my I kind of had a guttural response that if to tell you the truth, if that is a big concern for you guys, this is probably not the game for you. But I get it. Like we all like a long acetabulum or a long spine revision, you're going to be wiped, and it's hard staying engaged. So I mean, number one, take care of your physical needs. Make sure you're hydrated, make sure within, obviously the constraints of your work, you're getting good sleep, and make sure that you're getting good exercise. So you're bringing just your best physical self to the operating room and to your daily life. And I forget if it was David or Evan or somebody was, or maybe Ian, just recounting it. One of the worst things is when you're looking at a resident or a med student and they are just off in la la land. And I get it, like, 6 hours into front back acetabulum, your interest level is waning. But if you look at the attending and you look at the resident, their interest level, or at least their excitement level, is probably also waning. So the last thing they want to see is somebody that's not engaged. So you just got to dig deep for this type of stuff. It's like it's just an ultra, it's a marathon, and you just got to dig deep and just find it in yourself just to stay engaged. Think about the anatomy, look at the anatomy, think about the patient, listen to like the little micro movements of what's happening, listen to what the scrub tech is doing, look at the instruments, take everything in because everything, it's just a funnel or a hurricane of information that's coming your way. So, every instrument that's going in there, think, okay, all right, well, that's what a wheat liner looks like. Okay, that's what a Holman looks like. That's how they're placing the Holman. There is just learning every second of that case for you. Just open yourself up to that, and just try to stay engaged the best you can.
Yeah, I completely agree. I think it's very, very challenging, especially on those long cases, to find ways to stay engaged. But sometimes that is truly just understanding the situation and staying focused as best as you can, and continue to engage when appropriate. I think one thing, if the case, for instance, is going long because maybe there's been some challenges or what have you. I think trying to understand and take in how problems are solved in the operating room, I think is kind of invaluable. Every time we kind of get into a challenging case now as a resident, I'm always trying to understand how the attending is kind of thinking through that problem, thinking through that challenge. And I think that's one of the most valuable ways to kind of learn. So that's one way that you as a rotator is as Dr. Hahn had mentioned, picking up all of the little details can really help. In terms of like just physical well-being, it seems really silly, but if you know you're going to go into a big case, like go grab like a big glass of water and kind of drink that before, make sure you're hydrated. Whether it's like little stretching in the operating room before the case as you're waiting for the patient to come back in, whatever you need to kind of stay physically engaged, I think can be beneficial and helpful too. So these days never go away. They kind of start as a third and fourth year medical student, and they really only get longer. So finding little ways how you can prepare yourself for them and make sure that you're engaged and staying helpful throughout. I think that just starts kind of the learning process as a fourth year rotating student.
Yeah, thank you both for those responses. It seemed a common theme between the two was there's always opportunities to learn, even on those long, hard days. As a sub-I, you have such a great opportunity to learn, and it's important to take advantage of that. I'll move on to our last question of the day, and I'll ask all of our panelists to weigh in on if they could. What's one piece of advice to sub-Is that you could give about succeeding in the OR? What would that be? So we'll start with Dr. Canada, move to Dr. Laporte, Dr. Hahn, David, Ian, and then Evan. Dr. Canada?
So, my one piece of advice, first I'm addressing when you're doing a sub-I, you're not only uh, auditioning to be a surgeon or a resident there, but you're also auditioning to be their colleague. So keeping that in mind, my one piece of advice is attitude trumps it all. Being enthusiastic, being humble, and having a willingness to learn will take you further than any technical skill because as a fourth year medical student, you aren't going to have that technical skill that's going to make everyone talk about it. So attitude trumps it all.
Thank you.
I love that. I don't have a buzzword for this, so I probably have too many things at once. But I would definitely say, being a great part of the team is really important. At the end of your month, you want people to say, "How did we survive without Ian here?" or something like that. So you want to figure out how to be helpful and be helpful. You want to be part of the team, and it's been said a lot, but you want to read the room. You want to have really good social and situational awareness, and at the end of the day, you're all there taking care of the patients. And if you remain focused on that, you're always going to do a great job.
So I've got two things. One, well, like 1.5, because I already said one of them, be kind. Like I said previously, this is a bad day for the patient. So they're anxious, they're terrified, their family's probably anxious and terrified. So kindness goes a long way, and that shows, that is very apparent when people are kind. And the second thing is be present. Just just being there, as and spending time there, at the hospital with the residents, that goes a very, very, very long way because learning opportunities then abound.
I would say my theme would be communicate more. So, and that doesn't mean during the surgery necessarily. We talked about how that's difficult, but do a ton of communicating before the surgery. So before the surgery starts, make sure you've introduced yourself to everybody. We touched on this, but scrub techs can be a huge barrier for you, or they can be a huge blessing. And so going into the room, introducing yourself to the tech, the nurses, anybody in the room should know your name. No one should wonder who you are in the room. You're a visitor to someone else's house. You don't go there. They don't know who you are. Write your name on the board. Ask them, hey, can I open my gloves for you? Sometimes the nurse will say, just get them and I'll open them. But communicate a ton to the team before the case starts, and communicate a ton with your resident before the case, the night before, the morning of. Hey, I saw the schedule change. You should never be like going into the room and you don't even realize what case is about to happen. Like that should never happen. So you don't always have all the information that we do, but so the way you get it is communicate with us. Like you can never really communicate too much other than when the surgery is happening. When the surgery is happening, you can definitely over communicate, but outside of that, you can't really over communicate. So just kind of like Dr. Laporte said, it's, no one's going to say, wow, I missed that student if you didn't talk to anybody. So you have to communicate with the team for us to feel your presence.
My biggest piece of advice, I think, would be to take as many notes as possible, write them down, whether it's handwritten notes, whether it's the notes app on your phone when you finish a case. And it doesn't have to be like the steps of the case or anything like that, but what questions were asked, what was the setup of the room, how were you able to be helpful? Take notes on that because those long OR days, you'll be like, oh, I'll remember that. You probably won't. So when you finish a case, spend an extra 5 to 10 minutes, write down everything that you can about the case, any questions, any pertinent anatomy. It will really help you. I still have a log for my sub-I of things that I wrote down that I still sometimes reference, even now as a third year resident. Um, so just kind of generating that log and writing down as much to obtain as much knowledge as possible. And then it's been touched upon, but just, be respectful and say thank you. It really is a fun part of our job. I look forward every summer when we have medical student rotators coming with us. I think it brings up the morale. I think it's great to meet new people and work with them. So you're doing us a huge service, but just don't forget to say thank you and work really hard.
Yeah, I think mine would just be authentic. Be authentic in the questions that you ask in the case. Don't just do it because you think you need to do something. Do it because you're actually inquisitive and want to learn. Be authentic when you go into the OR. That's the last case of the day at 6, and ask if they need help. We can tell if you're just coming in to show face and really want to go home. So we can be like, no, we got it, but try to get into the case. Try to show them you want to stay late. Try to, after the case, go ask the consult resident if they need help. Don't do it with your backpack and your coat on because we already know you're leaving, and that's super easy to tell. So, and then just all those habits that you build now as a sub-I will take you a long way. So just continue. Once you're a resident, you're not above like the med student thing. So keep asking questions, keep introducing yourself, keep being nice, keep taking the light handles off after the case and stripping the bed down. And you don't have to wash the floors, but just think about what you can do to help the next case start. So just be authentic.
Thank you, panelists, for this parting advice. This wraps up our last panel of the day. I want to thank our panelists once again for your perspectives on how to excel in the OR as rotators and ending our sub-I summit on such a strong note. We appreciate you all being here. With that, I'll pass it back to our MSOS president, Amy, to share some exciting announcements and wrap us up for the afternoon. Amy?
Thank you, Precious. Thank you to all of our panelists, lecturers, committee members, advisors, and chairs for organizing this comprehensive sub-I prep panel. I know I learned a lot today. Definitely feel more confident going into sub-I season. So as we close on the day, I wanted to briefly highlight some exciting upcoming MSOS opportunities. We all know sub-Is can get quickly very, very expensive, and we're grateful to announce that MSOS will continue to offer scholarships to those of you who are attending sub-Is this fall to help offload some costs. Scholarships are worth up to $1,500 each, and applications are open on our website. Again, thank you to our sponsor, Depew, for continuing to fund these scholarships. Next slide. In addition, our 2025 Research Symposium is coming up next month on April 27th, featuring research from medical students across the country, and also panels on how to maximize the research year and how to successfully match into ortho. You can register for the event using the QR code that's on the screen, but otherwise the link can also be found on our website and social media as well. Finally, stay tuned for our committee applications, which open in May, our mentorship program applications, which open in July, and then many, many events this fall. To stay updated, make sure to follow our social media accounts on Instagram and also X. Now, for anyone who had to step out at any point during the lectures or panels today, we will be recording the summit, and we'll make sure to post all those on our website's resource page in the coming days. We'll make sure to email every single person who just registered once those are active. So keep an eye out for that email, and then also navigate over to our website to check out all of the other amazing resources that we mentioned earlier. As we wrap this up, want to again thank our MSOS education chairs, our committee members, our resident advisors, our faculty advisors, and everyone else for the many, many hours of work that went into planning this event. And of course, our fantastic panelists for volunteering their time and expertise. And lastly, thank you to all the students who are here today for spending your Sunday with us. We wish you all the best on your future sub-I rotations. We hope that today's summit helped prepare you to excel. Again, thank you and have a wonderful rest of your weekend.